Happy afternoon, and I cordially welcome you all to our Garbagudi Institute of Reproductive Health and Research. Myself, Muthulakshmi, Academic Coordinator at GGIR HR. It's my honor to take over the platform for today's CME webinar on behalf of GGIR HR. We proudly welcome all the speakers and doctors who gathered here virtually. General instructions: mobile phones on silent. You will be on mute throughout the session and your videos will be turned off. For any queries, please drop it in the chat box. Let's begin today's CME with a brief note on the journey of Garbagudi. Garbagudi was founded in 2011, where our pioneering work has led to the progression and implementation of the latest medical technology and methods to overcome male and female infertility. Garbagudi IVF Center is known for its extraordinary and overwhelming success rates, ethical treatments, affordable costs, with world-class infrastructure and humane touch. Now, Garbagudi is spanning over a decade, who's still serving as a beacon of hope for thousands of infertile couples. Recently, Garbagudi IVF Center is being awarded with Bangalore's fastest growing IVF center by Radio City. Garbagudi ranked third for its best treatment in South India and stood eighth place across India. Garbagudi, which is a chain of new generations in fertility treatment hospitals equipped with the state-of-art infrastructure and cutting-edge technologies like IVF, ICSI, PGD, etc., to address this ever-increasing infertility issues. Our experienced and dedicated specialists, nurses, and embryologists work to cater our couples' need and respond them quickly, as one of our Garbagudi way states that satisfied client is our best brand evangelist, and we aim in delivering results at higher standards. With the backing of such a capable and strong organization, GGIR HR, that is Garbagudi Institute of Reproductive Health and Research, is providing the preeminent training to the budding clinicians, embryologists, andrologists, and other staffs to mold them for the challenges of infertility treatment. GGIR HR is affiliated with Rajiv Gandhi University of Health Sciences for Fellowship in Reproductive Medicine, IMA-AMS, Indian Medical Association for Medical Infertility, Garden City University for Postgraduate Diploma in Clinical Embryology. We also provide ultrasound scan course and other residential and residential fellowship courses, which is GGIR HR certified. Students at GGIR HR are trained with tips and tricks, procedures and protocols followed at Garbagudi IVF Center, which has given unbelievable success rates. Now, we are glad to inform you all that we are spread with 7 centers across Bangalore in serving thousands of couples. Without further ado, let's begin today's CME. Speaker for the day is Dr. Nikita Murthy, who will be taking us through endometriosis and infertility. Dr. Nikita Murthy, an experienced infertility specialist with a passion for helping couples achieve their dream of having a family. Ma'am's passion for helping couples struggling with infertility led her to become the chief consultant at Kerry Fertility Center, and now she's a fertility specialist at Garbagudi IVF Center. Dr. Nikita ma'am, over to you.
Happy afternoon, everyone, whoever are listening to this CME. So I think till now, regarding PCOS, we've had a very elaborate discussion by Dr. Anita. And now I'll be going to another very important topic, which we commonly see in our OPDs nowadays, and that is endometriosis. So the E in endometriosis, according to me, stands for the word that it is very enigmatic disease. So what does enigmatic mean? It is a very mysterious disease, because till now it has been very difficult for us to elucidate what are the different pathophysiological mechanisms, why this endometriosis comes first of all, and why in some cases where there are huge endometriotic cysts, there are hardly any symptoms, and sometimes they even conceive naturally. And in some cases, though there are just spots or very low grade of endometriosis, leads to very severe infertility. So all these are still under research, and that is why I would like to say that endometriosis is a very enigmatic disease. So these are some of the celebrities who have opened up and discussed regarding their status that they have been affected by endometriosis. In the Western population, in our own Indian population, they have voiced out their opinion about this, basically because it takes a severe toll on their physical and mental health, and that is what we'll be seeing in the coming slides today. So a very famous academician, William Osler, has told that he who knows endometriosis knows gynecology. So just by this statement, you can realize that how little we actually know about endometriosis as of date today. So what is the definition of endometriosis? It is a chronic inflammatory condition characterized by the presence of endometrial-like tissue, that is the endometrial glands and the stroma outside the uterus. So it is most commonly associated with pelvic pain and infertility. So Sampson has been credited for providing the first theory on pathogenesis, and he has coined the term endometriosis in the year 1921. So 1 in 10 women have endometriosis during their reproductive years. There's a wide range of 3 to 43% among the fertile patients undergoing sterilization. So women presenting with infertility is around 20 to 80%. And out of these women, those who present with chronic pelvic pain is around 15 to 70%. So there is a very wide variation. And this is what we are trying to collaborate, what lesion leads to what type of symptom and what severity of the symptom. So endometriosis is 6 to 7 times more prevalent among the first degree relatives of the affected women. So a possible genetic or a hereditary factor is being studied. So fecundity rate. So the ability to become pregnant in a single cycle. So the fecundity is around 20% in healthy women population, whereas it drastically comes down to just 2 to 10% with endometriosis. And this depends on the age and the stage of endometriosis. So in stage 1 and stage 2, that is in very mild and moderate endometriosis, it is around 15 to 25% conceived, whereas only 2 to 10% in stage 3 and 4. Coming to the pathophysiology, there are various theories which are proposed for the pathogenesis of endometriosis. And the first theory being the Sampson's theory of retrograde menstruation and implantation theory. So as the title suggests, retrograde menstruation, and later it goes and implants outside the uterus. So menstrual dissemination of the endometrial tissue into the peritoneal cavity. And this in some women who have a disordered immune system, that is one who cannot identify and destroy these menstrual endometrial cells which reach the peritoneal cavity. In those women, these menstrual tissue then goes on to form the endometriotic spots and lesions. The second theory is coelomic metaplasia, or the Mayer's theory, and the induction theory. So based on the fact that cells from the peritoneum, we all know embryologically that the peritoneal cells, the ovarian surface, and the endometrial cells, they arise from a common embryological precursor, that is a coelomic epithelium. So a spontaneous metaplastic change in the mesothelial cells derived from the coelomic epithelium, that is, as you can see, a peritoneal cell differentiating into an endometrial cell can be one of the proposed mechanisms of developing endometriosis. The other theories are the vascular and the lymphatic metastasis theory, that is the Halban's theory. Like similar to how there is a retrograde menstruation, similarly, these implants traveling to the vascular or the lymphatic route can go and develop endometriosis. And this is one of the reasons of which have been proposed in distant endometriosis, that is the endometriosis outside the pelvis can be due to this theory. The fourth is the direct transplantation theory in the form of during surgery or anything like that. If there is menstrual tissue implanted anywhere outside, so that could lead to the endometriosis over there. Next is the endometrial disease theory. So superficial peritoneal implants are regarded as physiological findings and they can regress spontaneously. However, deep infiltrating endometriosis and ovarian endometriotic cysts are considered pathological lesions arising from cells that have undergone somatic mutations. So these mutations are believed to have been produced by certain environmental factors like pollutants, dioxin, and other endocrine disrupting chemicals. So that could be the reason why we are seeing a lot of endometriosis cases during the recent times. Next is the invagination theory. This is the most widely accepted model. So superficial endometriosis on the ovarian surface, which adheres to the adjacent peritoneum due to repeated bleeding. So blood and the menstrual debris which become trapped by the adhesions, they accumulate on the ovarian surface. So this leads to progressive invagination of the ovarian cortex, forming a pseudocyst, that is the endometrioma. Next is the ovarian cyst theory. So what could be the reason for deeper endometriomas? So endometrioma starting as a functional cyst, which become gradually infiltrated by the endometriotic implants. So this is a diagram depicting the same, the pathophysiology depicting the same. And also a lot of, you can see a lot of immunological modulators. So the immunopathogenesis also is very important. So that is what we are going to be discussing next. So the immunobiology of endometriosis. So defects in cellular immune mechanism, and this is mediated by macrophages and NK cells. Like we said, it is a state of chronic inflammation. So these impair the normal recognition and clearance of the refluxed endometrial debris. So whenever there is backflow, our body has to recognize this and destroy these cells. But when there is an impairment in the immune mechanisms, that is when it is not possible, and that is why they go to develop into endometriotic lesions. So tissue fragments attach to the peritoneal mesothelial cells and invade the extracellular matrix, where they persist and they proliferate. Immune cells in peritoneal fluid also secrete variety of humoral factors, that is the cytokines and the growth factors, which stimulate attachment and proliferation of this ectopic endometrium, and there is also local angiogenesis. So what are the molecular mechanisms associated with endometriosis? See, ectopic endometrium is resistant to apoptosis. So in normal women, what happens? The levels of the endometrial estrogen and PGE2 are low. This is because of the low activity of the enzyme aromatase and COX-2. So during secretory phase, the progesterone stimulates the 17-beta hydroxysteroid dehydrogenase, which converts the estradiol to less potent estrone. But comparatively, what happens in women with endometriosis is that the aromatase and the COX-2 activity are very high, which leads to an increased local level of tissue estradiol and PGE2. So what is this? How is this ectopic endometrium different from the regular endometrium? There are three distinct features. That is, number one, there is a very high local estrogen production. Second being the high local prostaglandin production, that is prostaglandin E2, and a resistance to the action of progesterone. That is, there is progesterone resistance. So this is a slide depicting the same. So as we said, it's a state of chronic inflammation. There is the prostaglandin E2 being very high. So through the activity of the SF1, there is a high level of aromatase and therefore a high level of estradiol. And similarly, because of an increased COX-2 via the ER beta, there is a decrease in the progesterone receptors, leading to a state of progesterone resistance. So like I said, increased progesterone E2 induces a classical inflammatory response. So there is a high MMP, that is a metalloproteinases, promote the implantation of this endometriotic tissue. Increase in the chemokines, these attract increased number of granulocytes, NK cells, all leading to a state of inflammation. Increased cytokines, IL-1 beta, etc. They promote adhesion, the shed endometrial tissue, and they help in the attachment to the peritoneal surfaces. Now talking about endometriosis and infertility. So how does it affect fertility? So there are different types of endometriotic lesions, what we need to understand. First, in the pelvic, there is peritoneal, ovarian, and deep infiltrating. And in the extrapelvic, it can be seen in any of the sites, basically. That is gastrointestinal, urinary tract, the scar endometriosis, vaginal endometriosis, thoracic endometriosis, and the other sites. So superficial endometriosis is basically the peritoneal implants and ovarian implants, and these respond to the menstrual cycle. There is something called as deep infiltrating endometriosis, that is proliferative fibromuscular tissue with sparse endometrial glandular and stromal tissue. It does not show significant changes during the menstrual cycle, and typically it is seen in the rectovaginal space and can involve the uterosacral ligament, the posterior vaginal wall, and the anterior rectal wall. The third being the ovarian endometriotic cysts, that is the endometriomas. So endometriosis and infertility. So how does it exactly cause infertility? So the first, that is advanced endometriosis can lead to infertility due to extensive adhesions, large endometrioma, and the distortion of the tubo-ovarian relationship. Mild endometriosis leads to infertility because of the peritoneal fluid abnormalities, the immune alterations, utopic endometrium abnormalities, ovulatory dysfunction, follicular and oocyte abnormalities, and due to reduced endometrial receptivity. So the HPO axis there is dysfunction due to the increased gonadotropin attenuating factor. So this leads to prolonged follicular phase, reduced peak LH concentration, disturbed follicular genesis, incomplete oocyte maturation because of a LH receptor defect, reduced ovarian response, luteinized unruptured follicle, and luteal phase defects. So the granulosa cell is impaired, and these are certain papers which report the different types of abnormalities which are seen in the granulosa cell function. And what happens to the oocyte itself in endometriosis? So what we usually see after doing IVF, we have a greater chance to see the oocyte in itself. So we see that there is dark central granulation, and in a microscopic level, there is spindle abnormalities, mitochondrial content is altered, and there is a zona pellucida hardening what is seen. So what are the tubal factors which are impaired in case of endometriosis? We have seen that there is abnormal uterotubal transport. So this is via hysterosalpingoscintigraphy, where directly, by assessing the tubal transport, which is very diminished in case of endometriosis because of the how it affects the ciliary cells in the tube. Also, there is altered tubo-ovarian relationships because of the distorted anatomy, and peritubal adhesion all leads to decreased function, and sometimes there is altered patency of the tubes as well. So peritoneal fluid and the follicular fluid alterations, because like I said, it's a chronic inflammatory state, there is a increased level of cytokines and also of the lymphocytes, macrophages, the NK cells and other cells, which lead to increased levels of reactive oxygen species. And because of this, there is a deleterious effect on the tubal function, the oocyte degeneration, sperm mobility, and it is toxic to the embryos, inhibiting implantation as well. So there is also an effect on the sperm function. So because of this increased oxidative stress, there is the cytokines causes the loss of the membrane integrity, enzyme inactivation, decreased sperm motility, and this affects the acrosome reaction and sperm oocyte function. And these are all very integral for the step of fertilization. So therefore, there is decreased fertilization rates in endometriosis because of altered gamete interactions and also compromised oocyte quality because, like I said previously, microtubules and chromosomal damages are there, nuclear and cytoplasmic aberrations are also there. So all in all, there is also a decrease in the embryo quality. So we know that bad embryos result from poor quality oocytes. We have seen that in endometriosis, there's an increased rate of nuclear and cytoplasmic aberrations, decrease in the blastocysts, which are seen at day 5, decrease in the blastomeres at day 3, and an overall decrease in the implantation rate as well. So what happens to the endometrial receptivity? So usually in endometriosis, there is a decrease in the integral molecules which are required for implantation. That is, there is a decrease in the integrin, decreased LIF expression during the window of implantation, and ultimately all of this gives a negative impact on the implantation. So because of the progesterone resistance, failure to downregulate the ESR1 during the implantation phase, absence of the mid-luteal rise of the HOXA10 and anti-endometrial antibodies, all of this has been implicated to decrease the endometrial receptivity. So these are all the micromolecules that I was talking about and how the levels are altered and what effects it causes on the female reproductive system. So summarizing all this, so the endometriosis, it affects the oogenesis, that is, there is a defect. There's an intrinsic ovarian problem, altered follicular microenvironment, all leading to decrease in the oocyte quality and therefore decreased embryos, decrease in the pregnancy rates and the implantation rates. So all this is because of altered peritoneal fluid, impaired granulosa cell function, abnormal follicular fluid composition, and all this decreases the pregnancy rates. So what are the clinical features of endometriosis? So we know that endometriosis, it begins at a very early age. Now also even the importance about endometriosis during adolescence, and also that it affects women during the prime years of their lives. So usually endometriosis is asymptomatic in about 1/5 of the patient. In the rest of the 4/5 of the patient, the common presenting symptoms are dysmenorrhea, non-cyclical pelvic pain, dyspareunia, and infertility. So the pain severity does not correlate with the disease severity, like I have stressed on before. So the dysmenorrhea, it affects around 85% of the patients. So in the recent ESHRE 2022 guidelines, the GDG has recommended that clinicians should consider. So when should we think about endometriosis? When they present with following cyclical and non-cyclical signs and symptoms. That is dysmenorrhea, deep dyspareunia, dysuria, dyschezia, painful rectal bleeding or hematuria, shoulder tip pain, catamenial pneumothorax, cyclical cough. All these are for distant endometriosis, cyclical scar swelling, pain, fatigue, and infertility. So any of these symptoms, we should always consider the diagnosis of endometriosis. So how is the diagnosis made? It is made based on the signs and symptoms. Transvaginal ultrasonography helps in aiding us towards making a diagnosis. In the ultrasound, usually it is seen as a cystic structure with low level of internal echoes surrounded by a crisp echogenic capsule in the case of a typical endometrioma. Then MRI is used for helping in delineating deep infiltrating lesions. It is highly sensitive and specific for this. And laparoscopy, earlier it was considered as a gold standard, but I'll be talking to you about this in detail in the coming slides. So transvaginal ultrasound. So TVS has limited value in diagnosing peritoneal endometriosis. So these are some important points which you have to note down, but it is a useful tool both to make and exclude the diagnosis of ovarian endometrioma. So TVS may have a role in the diagnosis of the disease involving the bladder and rectum as well. So the sensitivity is around 83% and specificity is 98% for endometrioma. So what to look for in case of a transvaginal ultrasound when you're doing it, and what do you see? Basically, you look for the endometrioma. If you check the ovarian reserve by checking the antral follicle count, the accessibility of the ovaries, whether sometimes it is adherent and fixed, especially in the POD, you might see that both the ovaries come and sit in the POD, forming the typical kissing ovary appearance, and also sometimes hydrosalpinx, adhesions, difficulty in the follicular monitoring because of the abnormal position of the ovary itself. So there is something called as the IDEA, that is the International Deep Endometriosis Analysis Group. They have given 4-step approach to how to assess during the transvaginal sonography, how to assess and look for endometriosis. Basically, this is a dynamic ultrasonography. So the first step is the routine evaluation of the uterus and the adnexa, along with sonographical signs to check for the concomitant appearance of the adenomyosis, presence or absence of the endometrioma. Next step is evaluation of the transvaginal soft markers, what we see. That is the site-specific tenderness, that is the probe tenderness, and also to check for the ovarian mobility. The third step is the assessment of the status of the POD using real-time sonography based on the sliding sign. Next is the assessment for DIE, that is deep infiltrating endometriosis nodules in anterior and the posterior compartments. That is the fourth step. This is given by the IDEA group. So next, as I said, MRI also may help to guide. It is not mandatory to do an MRI in all cases, but it will help especially in cases of deep infiltrating endometriosis, especially when you're planning for surgical excision of these endometriotic nodules or lesions. So also it is useful in case when you do an ultrasound, you're not able to tell what kind of a lesion, especially in case of atypical endometrioma. So in these cases, an MRI definitely helps. So usually in the MRI, the endometrioma looks T1, it is hyperintense, and T2 hypointense. And also in the GRE sequences also, there might be small loculations, what we see, the small dark spots, what we see. That is because of the hemosiderin deposits. So superior to ultrasound, MRI is in diagnosing the rectosigmoid and the bladder lesions, like I said, basically for deep infiltrating endometriosis, and it has greater specificity and sensitivity. Next, coming to laparoscopy, it is no longer considered as the gold standard, and it is now recommended in patients with negative imaging results, and also when empirical treatment was unsuccessful or inappropriate. Then laparoscopy. So to consider the complete evaluation, inspection of the pelvis in a clockwise or a counterclockwise fashion is encouraged. So each of the organs has to be checked and noted to see if there is endometriosis. So, like I said, the morphology of the peritoneal and ovarian implant should be categorized. They should be checked and categorized. So, we might be either seeing red lesions, red, pink, or clear lesions, or sometimes they may be pigmented, black or blue. So, basically, it or white lesions. So, all this is depending because of when blood is there, goes through the process, and that's what I said, like it becomes darker and darker due to the hemosiderin deposits. So these are the different appearances what can be seen on laparoscopy. It might be black, red, vesicular lesions, the endometriotic cyst may be present, adhesions between the pelvic structures, there is distorted anatomy which is seen, and also POD obliteration. So in early endometriosis, usually it is transparent or translucent. There is a serous bleb, clear papule, clear vesicle, etc. And that is there are non-opaque lesions. And later, because of the neoangiogenesis, it might appear red. Okay, polypoid excrescences, red spots, blood blebs, ecchymosis, and all is because of the blood. Next, what happens because of the disappearance of the bleeding? Black lesions might be then, which look as black spots, brown spots, blueberry spots, and this is what we call as a powder burns lesion. And that is all because of the hemosiderin deposits. Ultimately, appearance of fibrosis. So this is all a process. So might lead to, we see it as white lesions. That is a yellow spot, yellow-brown spot, opacification, or a puckering type of scar. So coming to the diagnosis of endometriosis, this is the Escherey guidelines which state how we have to diagnose endometriosis. So we always have to take into consideration the different signs and the symptoms and explore into the diagnosis of the endometriosis based on these signs and symptoms. And also along with that, we have to take into consideration, especially very important for this is the ultrasonography, like I said, and if required, an MRI, and in certain cases, we do the diagnostic laparoscopy. So there are different classification and staging systems of endometriosis. The first being the ASRM or revised ASRM classification. So in this, what it basically means is that when we do the laparoscopy, we see the different organs, that is the ovary, the peritoneum, right and the left, the cul-de-sac, and check for ovarian endometriomas and the adhesions. So based on the extent of involvement of this, there is a scoring system, and depending on that, there is the classification which is given as stage 1, 2, 3, or 4. So anything more than 40 is usually considered as a severe or the stage 4 endometriosis. So what is this ASRM classification? What is a drawback is that this is not basically based on the history, that is the signs and symptoms what are seen in the patient, and also that this classification, usually the pain and infertility does not correlate so well with the score, and it does not take into consideration the deep infiltrating endometriosis. So next, this is the SRM classification, like I said. Next slide. So therefore, there was a new scoring system, which is now even mentioned about in the recent Escherey guidelines, that is the endometriosis fertility index. So this is a scoring system which includes all three factors, that is the historical factors based on the age, duration of endometriosis, prior pregnancies, assessment of the adnexal function at the conclusion of surgery. So during a surgery, a staging is done based on the least functional score, that is of the fallopian tubes, the fimbriae, the ovaries, and this is done in a bilateral, how it is, the scoring is done. And assessment of the extensiveness of the endometriosis is done by the total revised ASRM scoring system itself. So this is how it is done. Depending on the tube, the fimbria, and the ovary, the least function score is assigned, and that is how the EFI is calculated. EFI, which is very less, is very severe. EFI, which is very high, means that it is a very milder stage of endometriosis. So that is what, depending on the least function, and also according to the historical factors. So an EFI of 9 to 10 indicates that there is a very high potential for natural conception, and estimated pregnancy rates of 55% and 74% at 12 months and 36 months. So this EFI can be, and as you see, the EFI of 0 to 3 has a pregnancy rate of only just 10%. So this scoring system helps to prognosticate and, as a counseling tool for the patients after doing the laparoscopy surgery, we can tell them based on this EFI score that what are the chances at conceiving healing naturally. So this is the NZN classification. This was done to complement the ASRM classification as it did not involve the deep infiltrating endometriosis. So this is based on different compartments. So a compartmental scoring of A, B, C, that is in the anterior and the posterior compartments. And according to this was also added to the ASRM classification. Coming to the treatment of endometriosis, it depends on two factors, that is the stage of the disease and the patient's symptoms. So the different treatment options which are available is one being the expectant management, the medical management, surgical management, ART, and a combination of the above approach. So what is the important factors? There are 10 important factors which you have to understand before treating the patient. A global evaluation of infertility. So when you see a patient with endometriosis, make sure to also check the uterus, the tubes, the male factor. Just do not allocate the infertility just because of the endometriosis. Any role for medical or surgical management? If you see an endometrioma, whether to operate or not, should you do an IUI or are you wasting any time? If you see the cyst, the endometriotic cyst, should you aspirate it or not? Which protocol you have to use for stimulation? Any suppression has to be done before starting the ART. If you do an embryo transfer, should it be fresh or should it be a frozen transfer? If you have recurrent endometriosis, you do a surgery and after a few years, you see that it is recurred. How to tackle that? And also concomitant adenomyosis diagnosis and treatment. So all these factors have to be taken into consideration. So the factors determining the treatment, like I said, is the age of the woman, the need to preserve fertility, the need for contraception, presenting symptoms, if it is pain, infertility, or both, the severity of the pain and the impact on the quality of life, the type, extent, and location of the lesion, involvement of the other system. These are the various drugs which are used in the medical management of endometriosis. But since we are speaking about endometriosis and infertility, so does medical management, is there any role of medical management in case of infertility? That we will find out. So the medical management, ovarian suppression is not recommended for women who wish to conceive because there was no difference in the pregnancy rate or the live birth rate following ovarian suppression versus a placebo or no treatment at all. So there is no role of medical treatment in case if the woman is contemplating for pregnancy. And this is in the ESHRE guidelines. There's a strong recommendation. So surgical management, where and all should we do surgical management? So according to the FIGO, the indications for surgical management is in younger women less than 35 years, where there is a short duration of infertility, normal male factor, normal or correctable ovulation disorder, endometrioma more than 4 centimeters with pain, if there is severe dysmenorrhea, hydrosalpinx, there is suspicion for malignancy, to improve the accessibility of follicles before the ART. These are the only indications for doing surgery in case of endometriosis. So what is the aim of surgery? So what are you going to do during the surgery? Excision or ablation of all the visible endometriotic lesions without damaging any vital structures, restoration of the normal pelvic anatomical relationship, prevention of the adhesion formation after surgery, removal of all the diseased tissue to the maximum extent possible, confirmation of the tissue pathology, and always the mantra is that the first surgery should be the best and the last surgery. So talking about a case scenario where a 30-year-old lady who's married and trying to conceive since 2 years has a AMH value of 2.2, which is fairly normal. The male factor being normal. And when you do a laparoscopy, you see that there are peritoneal endometriotic implants in the pouch of Douglas, which have been fulgurated. The tubes were patent and normal, and there is no adhesion. So what is the next line of management in this patient? So since she has already tried for 2 years, and we see on laparoscopy that there is a mild endometriosis, we can definitely offer her IUI for this patient. So for stage 1 and stage 2 endometriosis, if you do, while it is diagnosed during surgery, that is through laparoscopy, so clinicians should perform operative laparoscopy, that is either excision or ablation of the endometriotic lesions, including adhesiolysis, rather than performing only laparoscopy to increase the ongoing pregnancy rates. So during surgery, like I said, excision or ablation, there's a controversy of which is better, but few small trials have shown that there is no difference between the excision versus ablation. Next, electrocoagulation, if it should be done with monopolar or bipolar, again, there's a controversy. Peritoneal excision is the only way to ensure complete treatment because it is difficult to determine the depth of the endometrium, that is a peritoneal implant. Ablation therapy claims that it is as effective as excision and has the advantage of it being very simple, less blood loss, and shorter operating time. So like I said, operative laparoscopy could be offered as a treatment option for endometriosis-associated infertility in stage 1, stage 2, because it improves the rate of ongoing pregnancy. However, this is a very weak association, weak recommendation. So clinicians may recommend consider operative laparoscopy for the treatment of endometrioma associated infertility, as it may increase their chance of natural pregnancy, although no data from comparative studies exist. So reduced ovarian reserve in women with endometrioma. So why we've seen that usually when endometriosis is there is a reduced reserve. That is, have a lower antral follicle count and a lower AMH is seen in women with the endometriotic cyst versus no endometriotic cyst or even other benign cyst. So this was the error study in which it was also established that women with endometrioma experience a progressive decline of the serum AMH levels, which is faster than that of healthy women. So that is why time is a very important factor when you're treating endometriosis, and you have to advise them to conceive as soon as possible. So another case scenario, a 30-year-old lady with primary infertility of 7 years duration with history of dysmenorrhea. So a transvaginal scan showed a 2 into 2 centimeter endocyst on the left side, 3 into 2 centimeter cyst on the right side with a negative sliding sign, and that is what I said, it's suggestive of a pelvic adhesion. Her AMH was normal, AFC was normal, so she gives a previous history of laparoscopic cystectomy done 3 years back. So what is the best management strategy in this case? She's already undergone surgery, infertility is almost for a 7-year duration, she is symptomatic. The best option is to directly proceed with the IVF. So management of endometriosis in those who require IVF, to touch or not to touch. So there are certain factors which favor surgery, certain factors which favors expectant management. But two important things that we have to keep in mind is that if there are symptoms like there is pain, if it is present, we have to go for surgery. Second thing is the accessibility of the follicles. If they are accessible, then no need to go for surgical management. So surgical management in case of endometrioma is very important, that not only aspiration, the excision of the endometrioma capsule instead of just drainage and electrocoagulation of the endometrioma wall. It helps in increasing the spontaneous pregnancy rates. Just by doing an aspiration, there are higher chances of recurrence in endometrioma. But what is the negative impact of surgery? Absence of the plane of cleavage. So therefore, the healthy ovarian tissue might be removed along with the cyst wall while using the stripping technique. So healthy ovarian tissue is found in almost 97% of the cyst specimen. So direct proportional relationship between the cyst size and the ovarian tissue removal during surgical excision is seen. Coagulation for hemostasis may damage the blood supply. So all this may negatively impact her fertility. So a risk versus benefit should be counseled to the patient. So is there any role of ultrasound guided cyst aspiration? No, because as I said, there is a high rate of recurrence, inadequacy of the cytology, adhesions, and high chances of infection. So endometrioma, the important things what we have to keep in mind is that the AFC, the AMH might decrease when there is a presence of the endometrioma. The decrease in the oocyte maturation rates, fertilization rates, blast rate, and the number of oocytes retrieved and the available embryos all comes down. So this was a study, meta-analysis done by Hamdan in the year of 2015, the impact of endometrioma on the IVF-ICSI outcome. That is, if we do surgery and do IVF, or if we directly go to IVF, is there any difference? No, they have seen that there are similar reproductive outcomes between the two groups. So certain factors, what are the risk factors of doing the surgery? That is, there are higher chances of bleeding, pain, infection, visceral injury, impact to the ovarian reserve, premature ovarian failure by stripping off the healthy follicles as well, incomplete surgery disease recurrence in around 13% of the cases. It all depends on the surgeon's competency and the learning curve, and a potential delay of the ART. What are the risk factors of going for ART without doing a surgery? Accelerated progression of the disease, might be follicular fluid contamination, pregnancy-related complications, infection of the endometrioma, chemical peritonitis, increased requirement of the gonadotropins, undiagnosed occult malignancy is there, risk of cycle cancellation, and a challenging oocyte retrieval. So therefore, always we have to balance the risk factors, that is what favors surgery and what does not favor surgery. So in favor of surgery is that the symptoms usually improve after the surgery. So if it is symptomatic only, we have to go ahead with surgery. Sometimes that is in stage 1, stage 2, like I said, improved natural conception and ongoing fertility rate after surgery. If there is suspicions of malignancy, that is, you see a rapid growing rate during the ultrasonography, then we always have to favor surgery. And difficulty in accessing the follicles and the risk of pelvic infection during the ART, we have to go ahead with surgery. What is against surgery is that, like I said, it's a deleterious effect of the surgery on the ovarian reserve itself, higher risk of premature ovarian failure, and electrocoagulation may damage during the hemostasis also may contribute to the decrease in fertility. So always the risk versus benefit should be managed and always counseled and communicated to the patient, and depending on that, always a patient specific approach has to be taken. So these are the ASRM guidelines which are published in the year 2012. So in stage 1, stage 2 endometriosis, we see the age of the woman. If they are younger than 35 years of age, we can plan for an expectant management or an IUI after laparoscopy. In the age more than 35 years, or if they are older, older than 35 years, an IUI or an IVF is planned. In stage 3, stage 4 endometriosis associated with infertility, in certain cases, like I said, only when there is pain and inaccessibility of the follicles, only in those cases, a laparoscopy is advised. Otherwise, we can directly go ahead with IVF as an effective alternative. So, what are the indications of IVF in case of endometriosis? When there is an associated tubal factor as well, male factor infertility, failed IUI in minimal to mild endometriosis, failed IUI in moderate to severe endometriosis of less than 35 years, moderate to severe endometriosis beyond the age of 35 years, there is already a diminished ovarian reserve, low EFI, history of prior surgical treatment is there, then it is better to go for ART. So surgery for endometrioma, that is when it is associated with pain or the inaccessibility of follicles. So what protocol to use in case of IVF? We can use the agonist or the antagonist protocol. So based on the recent ESHRE guidelines in 2022, using any one of these protocols does not lead to, there is no superiority of one over the other. If it's an agonist protocol, you can go for an ultra-long protocol, long or a short protocol as well. So it's COH is, that is controlled ovarian hyperstimulation, is equally effective with both the agonist or the antagonist protocols in terms of implantation rates and the clinical pregnancy rates. So there are certain disadvantages of the ultra-long protocol. That is, a prolonged suppression may lead to the unresponsiveness, requirement of higher doses of gonadotropin, and the cycle cancellation rate is high. So should any pre-treatment be done for IVF? That is with the GnRH analogs, the combined oral contraceptives, Dynogest, or the cabergoline. So it is not recommended according to the recent guidelines. So what is the role of Dynogest? There are contradicting studies regarding this, and ultimately the dictum is that it may have a benefit because of the anti-inflammatory and the anti-angiogenic properties, but there is no conclusive evidence to use Dynogest before doing the IVF treatment. So if there is a recurrent endometrioma, why does it happen? Usually in 45% of the cases, after 5 years of surgery, recurrence can be seen. So there's a high risk for additional damage of the ovarian reserve. It can remain asymptomatic and does not progress in size with or without medical treatment. So the decision to operate depends less on the size than on the symptoms. So such patients are more likely to have signs of deep nodules as well, and that is how there might be recurrence. So spontaneous pregnancy after one surgery is around 41%, and spontaneous pregnancy after 2 surgeries comes down to almost half, that is 23%. So if you see a woman with endometriosis and she is planning to conceive somewhere but not in the near future, so is there any role for fertility preservation in the form of ovarian tissue cryopreservation or the oocytes? So this has been acknowledged in the recent guidelines and it is recommended that adolescents with endometriosis are informed of the potential detrimental effect of the endometriosis on the ovarian reserve and future fertility. So an option of oocyte freezing can be given to these women. So vitrification is ideal. So this is a slide summarizing the complete management of infertility. So different options, but it is to be applied and a shared decision making is to be done. Medical management, there is no role in case of infertility. surgical management, especially in stage 1, stage 2, for spontaneous conception can be done, and EFI estimation is important for as a counseling tool. Medical assisted reproduction is important in either stage 1, stage 2 who have failed to conceive with expectant management. Then a medically assisted reproduction in the form of IUI or IVF is offered. Thank you.
Thank you, ma'am. We are incredibly grateful for the time you spent with us, as your powerful and stimulating talk was highly encouraging. Your depth of the knowledge for the topic is a great source. Thank you, ma'am. I would like to conclude today's CME. I extend my heartfelt gratitude for the speakers in giving us an opportunity in getting a clear vision towards building up a career as an infertility specialist. I also thank all the participants in making today's webinar a successful event. Kindly contact GJR HR for further courses details on IFSI, that is Institutional Fellowship in Clinical Embryology, which is open for admissions. Thank you all.